Okay, good afternoon, everybody. Thank you very much for attending. I'd like to begin by acknowledging that we are on the traditional, ancestral, and unceded territory of the Musqueam people. It's my great pleasure to welcome Dr. Haley Merkeley to the summer seminar series. Dr. Merkeley is a hematologist at St. Paul's Hospital and a CBR member and the director of the Adult Red Cells Disorders Program of British Columbia. Haley completed her medical school, residency in internal medicine, and hematology training here at UBC, followed by a fellowship training at the University of Toronto. Haley's clinical and research interests are focused on sickle cell disease, thalassemia, and immune thrombocytopenia. And we're really happy and very grateful that she's able to speak to us today. So Haley, thanks very much for doing this. Take it away.
Thank you so much, Hugh, and thanks to everyone at the CBR for the invitation. So as you mentioned, my main job is red cell disorders, but immune thrombocytopenia, or ITP, is my side hustle. So I'm going to talk to you a bit about that today. So we're going to review the pathophysiology and treatment of ITP, discuss the gaps in ITP care in BC, which are numerous, and to highlight the role of a centralized ITP clinic, which we've established, myself and another CBR investigator, Dr. Jackson, as well as to present some preliminary data from our clinic. So what is immune thrombocytopenia, or ITP? Well, generally it's defined as a platelet count less than 100. Usually it's a cytopenia in isolation. And we further determine how long it's been established. So an acute ITP is less than 3 months versus persistent or chronic, where patients will have had low platelet counts for 12 months or longer. There is no rule in test for ITP, and it really is a diagnosis of exclusion, making sure that we've investigated for all the other causes of thrombocytopenia. Unfortunately, we don't have any large randomized trials on the management, and so there's a lot of controversy and variation in practice from hematologist to hematologist. And most of our treatment recommendations are therefore guideline-based. So there's some international hematology societies that have put forth guidelines, notably the American Society of Hematology, and then the International Consensus Statement. And that's really what we adhere to due to lack of rigorous data. So the incidence of ITP is estimated to be 2 to 5 per 100,000 persons. And the prevalence is about 10 to 24. And so if you look at our population of BC and the Yukon, we would estimate that there's probably somewhere between 1,700 and close to 2,000 people. It is not a disease without significant morbidity and even mortality. So there's a 4 times increased mortality for patients who do have severe refractory ITP compared to the general population. And most of that is related to infections because, as I will tell you, a lot of the treatment that we are doing is immunosuppression, which can therefore lead to infections, as well as severe bleeding events. So the course can be quite variable. There's patients who have a chronic relapsing and remission course where they could have a severe exacerbation that you treat them for, and then they stabilize and no further exacerbations for months and sometimes even years. Versus there are some patients who are quite severe, and it takes a lot of therapy to really stabilize them, and they may never actually normalize their platelet counts. But as I will discuss, the goal is really to provide a safe hemostatic level of platelets. There's a wide variety of how patients are affected, and so certainly platelet count doesn't always correlate with the clinical phenotype. So even patients with severely low platelet counts, they may not necessarily bleed, versus others could bleed at higher platelet counts. Remission rates are inversely correlated to age, and as you'll see, thus far our population of ITP patients in BC tends to be older. Sorry, there's an ambulance driving to St. Paul's. If you can hear that, it's quite loud. So what is the main pathophysiology? To be fully honest, it's quite complex and we don't really entirely understand it. But in general, it's thought to be an acquired autoimmune disorder. And so this is felt to be mainly caused by antibodies that bind to to glycoprotein markers on platelets, which are then recognized by macrophages and prematurely cleared. However, in recent years, we've come to understand that there's also a relative underproduction of platelets that's thought to be mediated by thrombopoietin. And so, as I'll talk about, one of the key newer drugs, although it's been about a decade since it's been around, it really stimulates thrombopoietin. We always want to think about ITP in terms of primary or secondary causes. So common secondary causes include things like SLE or lupus, certain viral infections, notably HIV, hepatitis C, bacterial infections like H. pylori. Sometimes it can be drug-induced, and often patients may have an underlying immunodeficiency. And sometimes we are, as the hematologists, are diagnosing that. They've flown under the radar for several years until they get ITP, and then we find out that they actually have an immunodeficiency that's associated with it. Another common cause would be malignancies, so there can be associated particularly with lymphomas. We also there are certain familial monogenic causes, so certain genes that can be associated with mainly immune system regulatory genes. And it's really important to tease out these secondary causes because often by treating the underlying secondary cause, we can fix the ITP and prevent the patients from being exposed to more toxic therapies than they would need to be. So when do we treat? Historically, we always kind of treated on the basis of platelet count, but as I've mentioned, not all patients bleed at the same platelet count, and so treatment should really be individualized to your patient. Generally, though, we get a little bit nervous once the platelets start to drop below 20 or 30. And what are our goals of treatment? So it's not to normalize the platelet count. It's really to provide a safe count that prevents bleeding. So typically this is around 30 to 50, but again, that's individualized for the patient. How do we determine whether patients have responded to our treatment? Well, there are some definitions that have been used in studies, and generally a complete response would be a platelet count of over 100 with no bleeding. And a partial response would be defined as over 30, again, with no bleeding. Another goal is to avoid irreversible therapies. So as I'll talk about, splenectomy is a second-line treatment. And obviously, we wouldn't want to do this unless we had to, because you can't really regrow. Well, you can regrow a splenule, but you can't really regrow a full spleen. And so we, want to make sure that that's being done appropriately. And then really starting to factor in what are patients' goals and preferences for treatments. So different treatments can have different time courses associated with them. So some of them are one-time therapies versus more chronic therapies, and they have their own unique toxicity profiles. So really, really important to have those discussions with patients about what their preferences are. However, sadly, most of our treatment decisions are really dictated by what extended medical coverage patients have. As I'll show you, there is quite a variability across the country in terms of province to province, in terms of what medications are covered for patients with ITP. So our general treatments are, we have, for our first-line therapies, the main workhorses of ITP care are corticosteroids as well as IVIG. And so these have, and the reason there are upfront therapies is because they have a rapid onset of action, generally days. And most patients will respond to them. So initial response rates can be up to 80 or 90%. However, not everybody does. The challenge is that these are not necessarily sustained responses. And so when patients are not responding to first-line treatment, or they are, rapidly decreasing their platelet counts after the treatment wears off, that's when we start to think about second and third lines of treatment. So our most common second-line treatments that are supported by the guidelines are splenectomy, which actually has a great response rate of up to 80%. And many patients actually do have durable remissions with splenectomy. However, it's a major surgical procedure, not without risks, and it's increasingly uncommon that this is acceptable to patients. Our main two pharmacologic therapies in second line are rituximab, which is an anti-CD20 medication. So again, targeting those B cells that are producing the antibodies that are attacking our platelets. And so the response rate is generally around 50%, although not necessarily all patients will have a sustained response. Where we have the best response rates for pharmacotherapies is really with our thrombopoietin receptor agonists. So there's three in clinical practice now: L-trombopeg, romiplastim, and then avatrombopeg, which is not on there. And patients receiving those medications will have responses of up to 70 to 90%, and they do tend to be more durable. There's other medications as well. So there's a spleen tyrosine kinase inhibitor called fostamatinib, and then different immunosuppressives as well, which tend to work less well compared to our TPO receptor agonists. So this is a colleague of mine, Dr. Donnie Arnold in McMaster, who has proposed this Canadian treatment algorithm, which is really based on the international guidelines. So, if you have a patient who needs treatment, our first line therapy is corticosteroids or IVIG. And then if they're not responding, you really move to second line therapies, and discussing with patients based on their comorbidities and preferences, whether that's rituximab, splenectomy, or TPO-RAs. And then if there's no response after that, that's when you would start to thinking about alternatives. So he also kind of describes this as a staircase analogy, where it's based on what you've responded to, you can continue to go up the stairs. Unfortunately, at least here in BC, we don't really make it to the third stair very often due to limitations of funding. So we're forced to often treat our patients with inferior therapies, so different immunosuppressives and cytotoxic agents, before we can get access to things like TPO receptor antagonists or rituximab. And so why do we use TPO-RAs in ITP? So the idea is that these mimic endogenous thrombopoietin, and will start to produce more megakaryocytes growth and differentiation, and thereby more platelets. So you can kind of balance out that platelet destruction that's antibody mediated with more platelet production. And we're starting to realize that many patients can actually be tapered off of these medications if they have a period of stability following treatment with them, and up to a small proportion of them, 10 to 30%, can actually have a durable response even after we discontinue the medication. As I mentioned, there's three in clinical use, and they each have a unique structure, toxicity profile, and binding sites. And so if you don't respond to one, that's not necessarily a class effect, and we would certainly circulate between these three different drugs to see if we can induce a response in patients. So as I had alluded to, access to these drugs in Canada is highly variable. So again, we worked with some colleagues across the country to look at what the drug access is like province to province. And it's so in places like Quebec, it's very easy to get TPO-RAs in second line. You just basically need to prove that patients have received first line treatments with corticosteroids or IVIG. They have thrombocytopenia and they're bleeding. In places like Ontario, you need to have failed a splenectomy. So it's a requirement that your patients have a splenectomy or a contraindication to splenectomy before you can get access to this, as well as failing two second-line therapies, which, as I mentioned, we know are inferior to TPO-RAs. Here in BC, it's really a case by case. There's no published criteria for when they will approve this. I have never, through pharmacare, been able to receive these in the second line. And previously, it was even hard to get them beyond second line, although more recently, I find it's a little bit easier to get them in third line. So again, wide variability province to province, which does lead to a lot of inequity for patients depending on where they are living in the country. So we wanted to look at what is actually happening to ITP patients in BC. So this is not, most of these patients are followed by individual hematologists scattered all across the province. There's no centralized way of following them. There's kind of no outcome monitoring. So we really didn't have a good pulse of what exactly was happening to these patients. So this is where the CBR comes in, and I'm very grateful to them for funding my second summer student who's looked at this massive undertaking of retrospective chart review that we've done. So what we did is we identified patients across BC, so in all the 6 health authorities, who had received IVIG, so again, that first-line treatment for ITP with the indication being ITP. And we restricted this to a 5-year period just for data manageability, and included those who were adults and who had what we defined as severe ITP or platelets less than 30. And so of the through this, we've for patients who had received IVIG for ITP, we identified nearly 1,800 records. You can see we're getting close to reaching the end. I think that 699 number has increased significantly due to the efforts of our summer students. But of the patients that we had screened, we identified 258 who met our inclusion criteria of platelets less than 30 and age greater than 18. And we did find that they were a little bit older. So the mean age was 61, which tends to be a little bit older than what we see reported in the literature. Most of our data collection thus far has been done in Island Health, so you can see that's why it's probably overrepresented there. But we are continuing to get through all the other health authorities as well. We found a nearly equal sex distribution, and it was kind of a 50-50 split whether patients had primary or secondary ITP. And the vast majority of them actually did have met that inclusion criteria of a platelet count of less than 30, consistent with severe thrombocytopenia. Interestingly, we found like a significant proportion of them, almost a third, had undergone surgery during the study period. So again, managing surgery with low platelets is a significant resource undertaking, making sure that you have all the appropriate medications and blood products to safely support a patient through surgery. So, part of this project is really looking at the resource intensity that these patients require. The vast majority of them had been hospitalized, so 80.6% at least once, with a mean length of stay of 12.2 days. So again, very resource intensive for these patients. Most of them had received over 2 lines of therapy, and we did find that patients did have significant adverse events. So important ones that we were looking at were things like infections and bleeding, toxicity from steroids like hyperglycemia, delirium. You can see here notably that even though, these were patients that were hospitalized, needing to stay in hospital for a long time, a minority of them actually had established guideline established second line therapy. So only 23% had received rituximab, and even fewer, 12% had received a TPO-RA. So this really opened our eyes. I mean, we knew this from our work in clinical practice, but it's always helpful to have data to support this. But it opened our eyes to what are the systemic gaps in caring for ITP patients in our province. And so, things that were highlighted to us were the variable management that we see, because they really are not centralized and managed by a broad group of hematologists. A huge one is the treatment access barrier. So again, access to those standard second line therapies due to the cost constraining measures imposed by BC Pharmacare. We felt that there were a lot of diagnostic inconsistencies, so variability in how complete a workup was. And we thought that there was definitely an opportunity to standardize it for care providers. We also appreciated that patients are exposed to suboptimal therapies that are potentially toxic. So a lot of the immunosuppressive agents that are maybe more cost effective can have significant organ toxicity for patients, and with the added issue of they're not particularly effective. And we're concerned that there was potentially a high misdiagnosis rate. So particularly patients with secondary ITP that wasn't being picked up with underlying immunodeficiencies or potentially monogenic causes. So leading to delayed or inappropriate treatment. And so we also wanted to talk to our patients and get a better sense of the personal impacts for them. So this is we started using an AI tool that will transcribe your conversation with your patient, and looking at, so I put a few transcripts into a word cloud to see really what were the key themes that came out. And of course, it's things that you would expect with low platelet counts like bruising and bleeding. But you can see another huge one is financial. So patients are really worried about not being able to afford therapies that they know are effective and can make them feel better. So we wanted to try and capture that more. And we turned to the literature to look at what matters to patients. So this is extracted from 2 ITP focus groups and 2 review articles. And this is a framing coming from value-based healthcare, looking at things like capability, comfort, and calm. So capability in the setting of ITP to patients meant maintaining and increasing their physical function, taking part in work, school, family, social activities. Comfort meant relief from anxiety and uncertainty. So in ITP, there's a lot of uncertainty about when will my platelet count drop again? Am I prepared to deal with that? Will I be in a situation where it's hard to do that? And, do I have to limit the activities I do because of that? And then calm, so accessing appropriate therapies, appropriate resources, and having a personalized roadmap for if things worsen. And I mentioned, the second line therapies and how it should be personalized to patients. So one thing that we realize that we should be doing for these patients is really having those discussions about what is important to them. So is it achieving a long-lasting response? Is it avoiding a long-term medication? Is it avoiding surgery? And really factoring those into our decision-making for patients was something that we felt would be important to do. And so we created a roadmap for a clinic that encompassed all of these factors that I've just mentioned. So it really is on the background of shared decision making. So at our initial assessment, we of course get all the necessary medical history, but we really focus in on the goals and preferences of the patients. When we're discussing options, it's a fulsome discussion about benefits and risks. And then looking, having patients make choices and integrating additional data components that I'll show you, and then determining a plan. So they're clear on what the roadmap is. We also wanted to kind of standardize the bleeding assessments that we were doing in clinic. So we have started an ITP using an ITP bleeding score to look at from visit to visit, how are patients doing? Because again, we know that platelet count doesn't necessarily correlate with the bleeding phenotype. And so, with all of these things in mind, we created a blueprint for a clinic and established an ITP clinic that Dr. Jackson and I run at our office across from St. Paul's Hospital. And so we call it the Thrombocytopenia Clinic, very creative name. But it's really to recognize that treating ITP is complex, and we do need a lot of shared decision making to ensure that our patients are getting the best treatment and having the best quality of life. So what does our blueprint look like? So I mentioned it's a standardized bleeding assessment. So the ITP bleeding scale that I showed you, it's a quality of life impact. So there's a patient reported outcome score called the ITP PAQ that patients do at intake and then periodically. And then we tailor their treatment plans really, really based on those their treatment responses and their values and preferences that I showed you. We're also starting to collaborate nationally. So we are part of the Canadian ITP registry, which initially started at McMaster, and we're the first site to join them in this, as well as a site at McGill. And we recently just received registry funding from Canada's Drug Agency to follow these patients longitudinally and look at their outcomes and treatments that they receive. So we're very excited about that. Another thing that we're doing is trying to capture treatments better. So this is a patient who had quite refractory ITP, and as you can see at the bottom there, that's his platelet count. So it's pretty close to zero for most of a month there. And so patients are often in and out of emerge and trying to keep up with their different treatments. If you're not the hematologist looking after them in the hospital that day, can be a little bit challenging. And so really trying to get that detail and represent it graphically so that we can use it as a tool not only for ourselves but also for the patients to see what they're responding to and inform treatment decisions even further. So as you can see at the top, this is a patient who received multiple courses of IVIG, received different types of therapies, so IV methylprednisolone, dexamethasone, and prednisone, which are oral steroids. Went on to receive rituximab, which is a recommended second-line treatment option, as well as two different TPO-RAs, so eltrombopag and romiflostim, and then other immunosuppressive therapies as well, such as mycophenolate and sirolimus. So someone who really took a lot of treatments in order to be able to increment their platelet count. And then another thing that we're also capturing in our clinic is the administrative burden. Because of our very poor access to established second-line therapy, it's a lot of back and forth and patient advocacy. So again, this is another patient who had refractory ITP, and each arrow represents a separate communication or form between the hematologist and all the various stakeholders involved in the care. So whether that's the hospital pharmacy, trying to get inpatient doses of expensive medications, whether it's patient support programs for medications like rituximab or eltrombopag, the patient's private insurer, BC Pharmacare, you can see it really is such a challenging system to navigate in its current state. And so finally, I wanted to present some data from the patients that we've seen so far in clinic in our established thrombocytopenia clinic. So we did a soft launch in September. And as of kind of mid-June, we had welcomed 47 patients. I think it's grown since then. Not all of those had new diagnoses of ITP. Many of them were existing patients. As you can see, many of them did come from inpatient referrals, so about half of them. Some came, a small minority of them in orange there came directly from the emergency department. And then the remainder in blue were made up by outpatient referrals. So, different family doctors or other specialists who were seeing patients and noted that they had low platelets. In most cases, well, slightly less than half, they were identified to have primary ITP. So, again, that's kind of keeping with what we saw with the retrospective data collection that our CBR student is doing. And then we notably identified a proportion that did not actually have ITP. They had an alternative cause of thrombocytopenia. So often that's things like liver disease or a myelodysplastic syndrome, which, has completely different types of treatment compared to ITP. So really important to identify those patients and spare them from the toxicities of ITP treatment. In terms of our secondary ITP, there was a variety as expected. You'll notice that the other category is the largest one there, and that was really kind of not clearly defined connective tissue diseases, but certainly on the spectrum of connective tissue diseases like lupus and rheumatoid arthritis, just not necessarily meeting diagnostic criteria just yet. We also saw identified some lymphoma associated, some immunodeficiency related, some related to antiphospholipid antibody syndrome. So highlighting the importance of doing a comprehensive workup to ensure that all of these things are being assessed for. In terms of patient-related outcomes, so we did find that these were variable patient to patient in terms of how they are, what their experience of their ITP is. There really didn't seem to be a difference between men and women, although we did note that women did have their mean minimum score was lower compared to the men. But for the most part, quite variable patient to patient. In terms of what patients were telling us about treatment preferences, the main one, as you can see, was wanting to avoid surgery. So, a splenectomy, again, as I had mentioned initially, really is not a favored option for many patients. So, highlighting that again, we thought was important, especially if pharmacare or other funders are asking you to do that for your patients. And so finally, how can we continue to improve care for ITP patients in BC? So our next steps are we are going to continue our retrospective data collection. Really the goal of this is to hopefully inform conversations with funders about improving access to second line therapies, especially the TPO-RAs, which have, as I've showed you, are very effective in the treatment of this disease. We're hoping to enroll patients in this prospective registry. We are going to start being involved in clinical trials for ITP. Again, a good opportunity to expand access to novel treatments. And one thing that we're hoping to do in future is actually do a fellowship in immunohematology and actually train people with expertise in ITP to continue to provide care for patients in BC. And so with that, I would like to thank the main drivers of this retrospective data project. So Tiffany Y is a medical student in Victoria and is a CBR summer student. So huge kudos to Tiffany for the absolute slog of charts that she's been able to get through this summer. We look forward to seeing her presentation in August. As well as Jessica Cron, who is a hematology resident who's been helping us. And then in the ITP clinic, my colleagues, Dr. Jackson and Annika, who is our assistant, and then the inception of this clinic would not be possible without dedicated funding. And to that, we're very grateful for our funders who are the UBC Department of Medicine and the Division of Hematology. And I am happy to take any questions you may have about ITP.
Haley, thank you very much for that. Cedric.
It's a great talk. I guess maybe it reflects my bias, but I had antiphospholipid syndrome being a bigger slice of the pie, so to speak, than you described. Are people routinely looking for this?
I would say, like, if you look at a cross section of all hematologists, especially in our retrospective project, no. In our clinic, yes, that is part of our screening. We always screen for antiphospholipid syndrome. Again, that highlights the variability in how these patients are being worked up.
Does it affect your treatment options or not? I suspect not, but anyway, what are your thoughts?
Yeah, I mean, well, certainly, it is important to identify, particularly for our young women who might have pregnancy complications associated with antiphospholipid syndrome. So that's why we feel it's so important to identify.
Thank you.
I think we have a question online from Ben Lai.
Hey, Haley, thanks for that. That was a wonderful talk. Two quick questions. First one's about diagnostics because it's, ITP is considered a diagnosis of exclusion, but there's all this stuff in literature about, detecting antibodies or, in fact, I believe we used to do that, but then because it didn't correlate well clinically, we've abandoned that at some point. What are your thoughts on that? Do you see that coming to fruition soon? Because to me, I looked at the literature and it's just been gaining so much ground in the last 4 or 5 years, but I see nothing in the clinical front so far.
Yeah, I mean, that's certainly not come through in the most recent ASH guidelines that are being updated. Like, I think, as you mentioned, yes, you can detect antibodies, but how clinically relevant are they is still the ongoing question. So we certainly are not doing any kind of testing for that. I think where we are starting to explore more are those monogenic causes of ITP. You and I have identified a family with, a monogenic cause, Ben, and we're able to start on directed treatment for that and significantly improve their ITP. So teasing out those patients who we think might. So we don't do genetic testing for everyone. It's a bit cumbersome for those of you who don't know. We have to apply for funding. We send it to a private genetics company in Finland. We get results in like 4 weeks. So, I mean, if anyone at the CBR wants to start a panel for us, we would be forever grateful. But it's, so it's resource intensive to do that. But definitely like our younger patients or patients who have other cytopenias that we think are immune, we explore genetic testing. At this stage, I think that's probably higher value than looking at antibodies.
Okay. And the second question is how to do the science. So I'm kind of in a similar situation where I have an APS clinic and I'm trying to do retrospective studies. And what I'm hearing from you, it sounds like you now have a clinic where you can centralize and data collect.
Yes.
And then the CBR has been wonderful in funding, research personnel to go through that. I find that one of the biggest challenges in clinical research is, how do we collate these patients? Because I don't like, there's no dedicated clinic for me. So sometimes I see patients on Monday, sometimes on Thursday, and and they're mixed in with other hematology patients in there. So I don't have a great way to collect them all together.
Yeah.
So yeah, I'm just wondering, like, what is your pipeline? Is it at the end of your clinic encounter with a patient, is somebody sitting down to enter data, or maybe at the end of the clinic, or is it more like in batches when there's a research personnel available in the summer or something like that every year?
Yeah, so Annika, our clinic assistant, she will actually so AI has been a great tool for us because we can so what Annika does is she actually collects a lot of the baseline data. So we have a kind of a standardized assessment, like lab tests that we would want at baseline. She puts that into Excel spreadsheets. And then we can actually kind of import that into our clinical notes. And then we have like kind of templated clinical notes. We have this. And so before every patient encounter, Annika's collecting data. The actual analysis of the data is a little bit more periodic. I think that will change once we join the registry, the national registry, where there's more support for regular data analytics. So I would say to you, Ben, don't reinvent the wheel. If there is something kind of nationally that already exists, tap into that and see if you can get some support. Particularly for rare diseases, it's a big priority for funders. And so the CDA actually has a call every year for registry funding and they do prioritize rare diseases. So I think, we were fortunate to get funding for that this year. So we will actually have more ability to analyze the data at regular intervals. And McMaster has a lot more infrastructure for that than we do. So it's fortunate that we're able to join in with them.
Dr. Prasdale.
Thanks. Thanks a lot, Haley. I've got a question that really evolves Ben's first line of questioning regarding diagnostics. And that is, I wonder what we know about factors that are consistent with patients going into remission.
Mm-hmm.
And really really about the molecular level.
Mm-hmm.
Can we be taking advantage of therapeutic development or even biomarker development, knowing more about what makes people go into remission?
Yeah. I mean, that's all still very much evolving, Ed. I was just at EHA, the European Hematology Association, and, there's all sorts of new drugs. And the common, phrasing is we don't exactly know how they work, but it does seem to, improve platelet counts. And some of these are like accidental discoveries. Now we're starting to use BTK inhibitors, which we use in, lymphoproliferative disorders. And we're finding out that, they benefit ITP. And so it's really not fulsomely described, but of course, everybody wants to find a biomarker and something that's targetable that you can develop a drug for.
Thanks.
Okay, Haley, thanks so much for the talk. So one of the things I noticed from one of the tables is that splenectomy has what was indicated as an 80% response rate. So what does that mean exactly? Like response, does that mean that it actually fixes the problem?
Yeah. So again, because the pathophysiology is that so once you have your antibodies on your platelets, they are targeted for destruction in the spleen. So with splenectomy is a highly effective therapy. So when you take that destruction away, patients, will normalize their platelet counts or at least get them to a safe hemostatic level. The challenge is that that's not very acceptable to most patients. I mean, if I was offered to take a pill or get my spleen out, I mean, that I would probably take the pill, right? And most patients feel similarly.
Right. So it means that it succeeds, like at least according to that definition, in 80% of the cases, right?
Yeah.
So
Yeah.
is the other 20%, is that because the etiology is more due to deficient production of platelets?
Yeah, potentially. There's a lot of T cells are thought to be mediated in the pathophysiology of ITP. So sometimes we take approaches whereby we target T cells, and we can see an improvement that way. Again, it's not we don't fully understand it. There seems to be multiple things going on.
In terms of risk assessment, I mean, understanding the splenectomy is not the first choice, but I mean, there's obvious risk in operating on someone who has low platelets to begin with. So, do you know, like, how do they approach the risk assessment for that?
Yeah, I mean, you do need a highly experienced surgeon, ideally. It is still considered, we will do it emergently in patients who we cannot get respond to treatment. So generally, we would be supporting them with platelet transfusions throughout the procedure. Once you take the spleen out, it usually the ITP in many cases will get better right away. I actually don't remember the last time I did a splenectomy for ITP. Ben, have you guys done one at VGH recently? No.
Not recently, and it's yeah, I think it's, as you said, it's just so much, just seems so much safer to do medical therapy than surgical therapy.
Yeah. But if all else fails, we would consider it emergently with a lot of kind of hemostatic supports in the OR, like platelets.
Thank you. Any more questions?
I think there's one online from Lily.
Hi, Dr. Merkley. I actually have a couple questions.
Sorry, Lily, you're a bit faint. I can't.
Can you hear me better like this? I'll just speak a little bit
Yes.
louder.
Yeah.
Okay. One of my questions was on the ITP treatment timeline, it shows like platelet count over time. And I think earlier in the presentation, you mentioned that platelet count does not always correspond with bleeding. Would it be useful to have like bleeding score over time on there as well?
Totally. Yeah, agree.
And another question that I had was you shared how women had an overall slightly lower ITP-PAQ score compared to men, and also ITP prevalence, or like ITP patients are about 50-50 male and female. Would you be interested in also looking at whether there are gender differences between men and women for patient preferences, for treatment options, or like the patient's primary concerns about their diseases?
Yeah.
Or also like sex differences in hospitalization rate or lines of therapy and adverse events?
Yeah, yeah. So, I mean that could potentially be a sub-analysis if that we could consider. I think it's not, women, of course, have menstrual periods, they have childbirth, they have pregnancy, right? So I'm not surprised that their scores are lower because they have a lot more to think about related to their ITP. If you want to get pregnant and have to stop your ITP medication because it's not safe in pregnancy, or you're worried about your ITP flaring in pregnancy, or just the bleeding you get every month with your periods related to your ITP. It's really, I think, important to quantify that sex-related difference and burden.
Thank you. I haven't really thought of that as like a reasoning for why you would look into this, but that's a very good point. And my last question, kind of related, was what is the perioperative management in ITP, given that treatments are often immunosuppressive in nature and that sometimes splenectomies are done as the treatment option, or just in general, patients might have other surgeries?
Yeah, so often it's other unrelated surgeries. So, for example, that one guy I showed you the graph of, he had a mass in his chest that needed to be removed because there was a concern that it could potentially be a tumor. And so, typically, it's drug therapy to try and get the platelets as high as we can. The target that we're aiming for somewhat depends on where the surgery is and whether it's a critical site. I mean, for most surgeries, we would want the platelets to be at least 50. So typically we're doing, if a patient is responsive to frontline therapies, we're doing, steroids or IVIG to try and get that up. Many patients may still be responsive to them. They just don't have a durable response, but you can get their platelets up enough to safely perform the surgery. Sometimes we have to give additional platelets throughout the procedure. The platelets will not necessarily last long because the antibodies will attack the platelets as well, but it can often provide some hemostatic benefit for the duration of the surgery. Sometimes this would be a scenario where pharmacare might be a little bit more lax in giving us access to TPO-RAs to try and get things up for surgery, and really just give us. So I had a patient like this who needed a surgery, and they just gave her a couple of months of funded TPO-RA, and then they're like, okay, you're good from your surgery. You don't get any more access to this. You have to deal with your platelets of 20 that don't respond to anything. So that can be an option sometimes too.
That's really interesting. And this is always done when patients with ITP have surgery or have surgery planned. I was doing some chart review for a study that was looking at perioperative management in MPNs, and I guess the disorders are different, but I found that it was really hard to find documentation of any hematology consult before the surgery.
Oh yeah, not surprised by that. People usually get scared by low platelets, especially surgeons. So I find, just the nature of what the disease is often, that does trigger us being involved, as opposed to something like an MPN.
Thank you. And just one last question. Is the management of ITP similar around pregnancy compared to surgery, or is it more complicated because pregnancy is quite long compared to like surgery?
Yeah, great question. So there are some differences. So ITP can definitely flare in pregnancy, and patients can get lower counts than their pre-pregnancy baseline. We still have the same kind of thresholds for platelets. So generally, if they're above 20 and they're not bleeding, that's fine until the time of delivery. And usually pre-delivery, we're trying to optimize platelet counts. So, the thing that we would want the platelet counts to be highest for would be if the patient wants an epidural. So that's a critical site, and we don't want any bleeding there. So most anesthesiologists who are administering an epidural would want platelets above 75 or 80. So often we have to do therapies to get the platelets up before. So we would preferentially use prednisone in pregnancy as opposed to dexamethasone, just because it's better studied. We often would try and avoid it in the first trimester because there's increased risk of clefting of the lip and palate. TPO-RAs are not used in pregnancy. We can use rituximab, although it does cross the placenta and can cause some B-cell aplasia in the fetus. So again, we're having very personalized discussions with patients about the risks to them, the risks to their fetus. But for the most part, the ones that I have managed have gone well.
I remember in our meeting yesterday, you mentioned that dexamethasone was primarily used in our area. Is there a reason why prednisone isn't used preferentially, given that it's more studied?
It's ease of use. So dexamethasone is a 4-day course, as opposed to prednisone. Usually patients are on for 2 weeks and then have to taper.
Oh, I see. Thank you so much. And that's all of my questions.
Okay, thanks. Are there any final questions? Okay, hearing none, I'd like to once again thank Haley very much for the presentation. Thanks a lot.
Thanks, guys.
So everyone, please remember Research Day, Wednesday, August the 12th. The summer students, another heads up that there will be a practice session likely the week before, so please stay tuned for that. Thanks again. Have a great day.